So, okay. Um, Speaking of the boards, here we go. So this is um, the kind of breakdown of questions on the sleep boards. So as expected, a lot of it is sleep-related breathing disorders, insomnia, normal sleep, etc. But 7% is the parasomnias. So typically the way we break these down is non-REM parasomnia, REM parasomnia, and other. We're going to be talking about all of those today. Um, and there's a roughly even breakdown on the boards between these various things. So, you know, knowing enough about these will get you at least 7% of the exam, right? Um, just general pearls for the boards. One, it should be the first thing you should do when you're confronted with a question or a patient who's got symptoms that could be a parasomnia. Develop your differential diagnosis and start kind of crossing those things off pretty quickly. And things that can help you are, is there or is there not amnesia to the event? What is the semiology of the event? Which means what does it look like? How does it evolve? What is the age of the patient? Certain parasomnias are much more likely in children versus adults and vice versa. How frequently do they happen? And then are there any EEG characteristics that you might look for? Most parasomnias do not require EEG or PSG-based diagnosis, with one exception. But knowing what might be helpful or not can help guide whether you order a sleep study, and if you do, what exactly you're looking for. Okay. Number two, memorize the ICSD criteria. Not only is this good for the boards, but it's also helpful for actually narrowing down a diagnosis. And then again, recognize unique PSG patterns, as well as common treatments for all parasomnias. A theme here is going to be most parasomnias don't actually require that much therapy, at least not directed pharmacotherapy, but there are some common trends there. Okay, so diving into it. Definitions first. The best definition, I think, of a parasomnia is the one that I've shown you here, which is an undesirable physical event or sensory experience that happens around sleep. So it could be going into sleep during the sleep period or coming out of sleep, those kind of transitional events. So sensory or motor experience associated with sleep. When complex nocturnal behaviors happen, can give you a clue to what you're dealing with. Remember, we talked about developing that differential diagnosis. So sleep-wake transition disorders of arousal happen during the period of drowsiness and light sleep that tends to happen early on in the sleep period. Non-REM parasomnias, as you can imagine, happen in non-REM sleep. REM parasomnias happen in REM sleep. And if you're trying to make a differential between parasomnia versus seizure, let's say, which is infrequent, but occasionally does come up when the event happens, can to some degree point you in the right direction. Most seizures happen upon falling asleep or upon waking up. Most do not happen in the middle of the night. That's not 100% true, okay, but most don't happen in the middle of the night. So when you're getting that history, the timing of the event can be an important clue. Parasomnias fundamentally represent overlapping states in the brain. So the kind of catch-22 of a parasomnia is how are we evincing complex motor or sensory behavior or experiences, and yet maintaining amnesia to the event. And the idea is that we've got parts of the brain that are active and parts that aren't. So you have simultaneously overlapping states. This is made possible by something called central pattern generators, which you're probably familiar with, even if you haven't heard the term exactly. But the way a central pattern generator works is it is a group of neurons that essentially works as a heuristic for complex actions. In other words, with development, experience, practice, etc., the brain can kind of compartmentalize complex motor tasks so that you just have to activate a small cluster of neurons in order to set off a cascade of complex motor behavior. Some of that is learned through practice. Much of that is innate and sort of built into the anatomical structure. But things like locomotion, chewing, blinking, things of that nature are more or less innate. Whereas more complicated upper extremity movements and even certain types of speech, simple speech patterns, can have these central pattern generators that develop over time. And you know, it's a matter of efficiency, right? If you had to plan, you know, if you're speaking a sentence and you had to plan every individual position of the tongue, every position of the lip, modulate your breath control, control the diaphragm, et cetera, it would take over 100% of your cognitive capacity, right? So, so one of the things that happens with learning, one of the ways that learning works is that complex behaviors are condensed down into ever simpler heuristics. So fundamentally, those are known as central pattern generators when they involve a motor activity. So the reason I'm talking about this is, you know, we're talking about parasomnias, these complex sleep behaviors. We can see very involved motor activity, sleepwalking, sleep talking, etc., even though we're asleep. And the reason we can manifest those complex behaviors is that a small arousal in the right part of the brain, if it happens to hit one of these central pattern generators, can kick off very complex behavior. An arousal not in a central pattern generator is not going to kick off complex behavior. You might have a small motor movement or something much simpler. So I think that's kind of a key component to understand. You'll also see activation of central pattern generators in certain types of epilepsy, for example. So it's not like with a tonic-clonic seizure, right? It's not that you're getting alternating electrical activity in the flexor and then extensor motor cortex, right? You're getting activation in an area of the motor cortex that controls upper extremity movement, and the on and off signals create the tonic and clonic movements. You can also see more complex seizure semiology, lip smacking, eye blinking, the kind of temporal lobe seizure type stuff. Okay. Questions about that before we go into the specifics of different types of parasomnias? This is not something you need to memorize in great detail, okay? It's just, I want you to be familiar with how the brain generates complex behaviors with minimal area of cortical arousal when you're asleep. Okay, so on to the good stuff. This is all you need to know about parasomnia. So this is directly from the ICSD-3, and we're not anticipating any changes in the nosology anytime soon. Occasionally, as you move from one version of the ICSD to the next, we'll reorganize things. You guys have you had the insomnia lecture yet? Yeah, so you probably heard moving from ICSD-2 to 3, there was a massive shift in how we, you know, conceived insomnia, taking whatever, 9 different subtypes of insomnia, condensing it down to 3, short-term, chronic, and other, right? But the parasomnias have been relatively stable, and I think we'll stay that way over time. So it's divided up into non-REM parasomnias, which you'll sometimes hear referred to as disorders of arousal, REM parasomnias, and then other. There's a lot of stuff on the others, but some of these are garbage diagnoses, right? Parasomnia unspecified due to drug, due to medical condition, which we very rarely use. But these are kind of interesting. So we're going to start with the non-REM parasomnias. That's our first 45 minutes or so. Then we'll take a break. We'll talk about the REM parasomnias for another 45 minutes or so. And then you're done with me and you'll learn about RLS. Okay. So all disorders of arousal, also known as non-REM parasomnias, share these 5 features. They are typified by recurrent episodes of incomplete awakening from sleep. There's a lack of an appropriate response to intervention. There's limited or no cognition or dream imagery, because again, we're in non-REM sleep. There's partial or complete amnesia to the event. And then E, as always, it's not explained by something else. Okay, so what do we make from this? These are essentially incomplete awakenings from sleep associated with amnesia, associated with some ability to interact with the world, but that is incomplete as well. Fundamentally, that's what we're dealing with a disorder of arousal. This is not a slide to memorize, but just as an FYI, most of the time, these are sort of idiopathic or potentially linked up with another sleep disorder. It's very rare that you go looking for a primary cause of a parasomnia. So this is kind of non-clinical, but there are some recognized predisposing factors. This particular HLA haplotype happens to be associated with an increased risk of parasomnias and is responsible for some familial parasomnias, especially sleepwalking. There are polymorphisms in the long arm of chromosome 20, which again, you're not going to test for, but if you're seeing a patient who got a chromosome analysis for some other reason, that might pop up. Importantly, children and adults with developmental delay or intellectual disability are more likely to have parasomnias compared to typically developing kids or adults with normal cognition. And apropos to your later talk today, sleep-related movement disorders, or really anything that's disrupting sleep, is a very common trigger for parasomnias. So most of the time clinically, when you see somebody with a parasomnia, it might be the reason they're coming to see you, but it should very often prompt a search for exacerbating or triggering factors. You might not do a whole lot with the parasomnia, but it should set you on the hunt for other sleep disorders. Okay, precipitating factors. This is going to be a theme throughout the talk. So for non-REM parasomnias, again, we're talking about disorders of arousal, non-REM parasomnias, the more slow wave sleep or delta sleep you have, the more likely it is that you're going to have parasomnia. Impaired cortical arousal, anything that raises your arousal threshold, is more likely to give you a partial or incomplete arousal, and therefore a parasomnia. And then anything that causes sleep fragmentation. So again, this kind of explains the 3 main groups or triggers that we see in non-REM parasomnias. Enhanced slow wave sleep, kids, people recovering from sleep deprivation, impaired cortical arousal like Z drugs, right? And anything that causes sleep fragmentation, periodic limb movements, OSA, stress, etc. Okay. What the event looks like can give you a clue to what it is and can also help you decide what to call it. But I think it's important to understand that we're essentially dealing with the same underlying cause. It's just, well, for example, a confusional arousal is a partial arousal from sleep, but we're not getting significant motor activity. Whereas sleepwalking, somnambulism, is a partial arousal from sleep that is associated with dislocation from the bed. If you're measuring the EEG, nothing is different. It's just, do you get out of bed or not? It's the same underlying issue, but you call it something different. Similarly, a sleep terror, another type of non-REM parasomnia, has the partial arousal, has the motor activity, and has limbic activation, so heightened emotional response, amygdala activity, etc. Again, fundamentally, it's still an incomplete arousal from sleep, but which area of the brain it happens to be activating gives you a different clinical picture. All right, so let's start talking about these kind of individually. So non-REM parasomnia's subcategory, confusional arousal. These are defined as partial arousal from sleep that progresses to sitting up in bed, usually associated with verbal confusion, kind of puzzled, confused behavior, disorientation, followed by a return to sleep. If you're getting out of bed, it's sleepwalking. If you're not, it's a confusional arousal. So you tend to see this kind of cycle here, a sudden arousal from slow wave sleep, confusion along with related behavior, amnesia, rapid resumption of sleep. There it is. Let's see what one of these looks like. Really quick, let me just make sure I am sharing this with sound. Hopefully that does it.
Good, let's go bed.
Where is he?
Who?
The holes.
What holes?
What? Mm.
So kind of a lot happening there, but if we break it down, first thing you see, there's some kind of uncoordinated, almost choreoathetoid, purposeless motor movement associated with the arousal. It's not just a stretch, right? At some points, you could be convinced that's all it is, but there's this like conductor kind of movement with the fingers. Ah, okay. Looking around.
You home in bed? Good, let's go bed.
Where is he?
So she's talking to him. He's responding, but nonsensically. Where is he?
Who?
The holes.
What holes?
The holes. And then
Uh-huh.
incomprehensible muttering.
Are you good?
Yeah.
And then there, that's the full awakening at the very end. So if you were monitoring EEG, for the majority of the video, you'd see slow wave sleep at the very end, finally the arousal and awakening. Okay. This is what that could look like on a sleep study. This is a patient in the lab being tested for apnea who really has a respiratory event here, right? Has a partial arousal from sleep, but is still in slow wave sleep here. And I wish we had a video for this, but is flapping his hands and quacking like a duck and has no memory of the event. You'll see a fair amount of these in the sleep lab, and you're going to rely on the sleep tech to kind of record what's going on. But the behaviors can look like almost anything. Confusion arousals are reasonably common. They're essentially universal in young kids, and they become less frequent over time. But up to 4% of adults will have recurrent or frequent confusional arousals. Again, that's more likely in folks who have untreated apnea, more likely in folks who have untreated RLS, et cetera. It's generally thought that confusional arousals are benign, but when you look at co-associated symptoms and conditions, half of them had clinically relevant anxiety, 60% of them had depressed mood, 20-some% actually had a diagnosis of bipolar disorder, 13% had OSA. That doesn't mean that confusional arousals are causative, obviously, but these underlying factors here tend to be associated with confusional arousals because they tend to be associated with sleep disruption. Right? OSA is obviously a sleep disrupting factor. Anxiety and depression can alter sleep architecture in reasonably standard ways. Same with bipolar disorder. So again, the idea with confusional arousals is not that you should treat them, but that it should prompt you to search for other underlying conditions that might be clinically relevant. Treatment. Rarely need to do anything. Avoid sleep deprivation. It seems obvious, but some people need to hear that. Following a regular sleep-wake pattern is an important part of avoiding sleep disruption. And then you want to limit exposure to central nervous system depressants, alcohol, sleep aids if the patients don't need them. And again, you want to manage those comorbid sleep disorders. You'll see tricyclic antidepressants enter in with a question mark on a whole lot of these conditions because of their relatively REM suppressing effect and their other alterations of sleep architecture. For years and years and years, folks have looked at TCAs and antidepressants and benzos and so on and so forth as treatments for parasomnias, although they're almost always not. Okay, I will say, so having just spent some time saying don't treat them, I will tell you I have at least one or two patients in whom I am treating confusional arousals. And it's for safety reasons, which you'll see later in somnambulism. So the one that comes to mind is a little kiddo with developmental delay. He's GJ tube dependent and has some mild apnea that's treated, but has very frequent confusional arousals, and during them would often pull out his tube. Yeah, and so that was an ER visit every time in the middle of the night. And we tried a few different meds to try and get that under control. Ultimately ended up with clonazepam. That worked quite well for him. So you hope that these, in kids anyway, are developmental sort of stage-specific phenomenon, and eventually kids may grow out of it. That's not true for everybody, but it's true for most people. So that would be an extreme case, but again, you're almost never going to treat it, but not absolutely never.
In children, is sleep deprivation the reason for focus confusion?
It's a good question. So rarely, but possibly. In kids, healthy, typically developing kids, often it has to do with the fact that they just have so darn much N3 sleep, right? So if you look at a graph of the relative sleep stages over time, the amount of N3 sleep, slow wave sleep that we have as a young kid is significant, 20, 30, 40%. Of the total sleep time. With age, that declines to maybe 10 or 15% in early adulthood, and then that continues to decline with age. So, excuse me, so that an elderly person might have zero N3 sleep. But the more N3 sleep you have, the more likely it is that you could have a parasomnia arising from N3 sleep. So that's one. Your denominator is very big, so the likelihood goes up. The other thing is in N3 sleep, there's greater cortical hypersynchrony, especially in kids. And I realize you guys haven't seen too many sleep studies yet, but especially whoever's starting at Rainbow, when you see an arousal in kids, in an adult, it might be, a quick little thing. In kids, it's this hypersynchronous, sort of huge slow wave that kind of looks epileptic. But that is just a manifestation of the high degree of cortical synchronicity that's present in kids, and that's magnified in N3 sleep. In other words, in N3 sleep, what tends to happen here in the cortex propagates pretty easily back here, as opposed to when we're awake, neuronal activity tends to be quite localized. So the reason I bring that up is kids have a lot of N3 sleep, and any arousal in N3 sleep because of the cortical hypersynchronicity is more likely to trigger parts of the brain responsible for motor movement and therefore trigger.
He will get up and the common words that I hear is like no, 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 or yes, 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 or he something like, I refuse to give him, and the day you're like, you didn't give me this, he will be repeating that, and then he'll go back to
The mom guilt.
Yeah.
Is-
He's holding you accountable. Yeah. Yeah. Yeah, I mean, in a 4-year-old, just about every 4-year-old, and pretty frequently. So we'll get to this a little later, but you're more likely to see them in the first half of the night as opposed to later on in the night, because that's when we tend to have our slow wave or end sleep, as opposed to something like a nightmare or a REM parasomnia. You have more REM later on. So those things tend to cluster in the latter third. So, yeah, but that sounds pretty normal to me.
Yeah, that's right.
Okay, well, the natural extension of the confusion arousal is one that actually gets you out of bed, and that's sleepwalking or somnambulism. So that's, again, an arousal followed by confusion, automatic behavior, and displacement from the bed. That's the kind of key feature. This may include kind of simple, purposeless activity, wandering around the room, sort of fumbling with things, to more complicated behavior, operating machinery, turning on the stove, getting something out of the cabinet, etc., all the way up to kind of more complex, violent, inappropriate, agitated behavior. That's very rare, but you'll see this in the news, sleep driving and sleep sex and sleep homicide. And I mean, that's, again, extremely rare, but it can have big consequences for the patient and their, people in their immediate surroundings. And it has legal ramifications as well. So, we're in a low litigation field, thankfully, but if you are called to be a witness or something like that, very often it's because of this. Somebody is claiming, rightly or wrongly, that
You did something.
exactly. And so it's not always easy to tell, but that's an area where your expertise can be to use. Okay. Sleepwalking is also very common in kids. It's not as ubiquitous as confusional arousals are, just because it's a more complex, involved set of actions. Peak age is 4 to 8 years. Again, 1 to 4% of adults have recurrent somnambulism. It does tend to run in families. The lifetime prevalence in an adult is about a third. So they've had sleepwalking at some point, but it's very rare to have recurrent sleepwalking. Typically, it's a few minutes. Rarely it would be more than that. And as we mentioned, it may involve kind of complex behaviors. Some of these complex behaviors are enough to warrant their own diagnostic name. So sleep-related eating disorder we'll talk about, and then the sexsomnias we'll talk about briefly as well. Those in particular, as you can imagine, can have legal ramifications. Okay. What am I showing you here? Let's see. So this is a patient in the sleep lab in delta sleep, as you can see on the EEG. There's a sudden increase in the chin tone. He sits up. There's fast activity here in the frontal leads, but for the most part, he still is in delta sleep. And then he proceeded to kind of walk around the sleep lab. So most of the time, you're not going to capture parasomnia in the sleep lab, but if you do, paying close attention to the EEG activity is really important. Okay, so that said, the semiology of sleepwalking is not as reliable as it is in a confusional arousal. There's a much wider array of behaviors that can happen. And especially as we move on to the REM parasomnias, what non-REM versus REM parasomnias look like is really important to distinguish what you think it is, because again, it's not likely you're going to see it in the sleep lab. But the reason I bring that up is we're going to watch this video. This is an arousal that occurred out of N3 sleep, but it looks a lot more active than you would imagine sleepwalking is. Let's see. So he's still asleep here, right? He's kind of doing his purposeless. Right around here, I think, is when really old rhythm, maybe. Back. So that's a tricky one, because if that patient or his bed partner were explaining that event to you, I don't think my first assumption would be sleepwalking, right? I might think REM parasomnia. We'll see those in the next hour. I might just think a fully conscious arousal, right? But in this case, the EEG was very clear. This is ongoing N3 sleep, so this is a non-REM parasomnia. Interestingly, this can happen.
I was going to ask about it. Yeah.
Yeah, the dream material. So again, this is a confusing element. So
Right.
if the patient says there is some dream material or they have a partial memory of it, generally that's kind of steering towards a REM parasomnia, but it's not pathognomonic.
Huh.
The one thing I can say is usually the dream material in REM parasomnia is crystal clear, it's vivid, it's complex. If you happen to get something like this in a non-REM parasomnia, it's usually more vague. Something was coming for me, or that sort of thing. Okay, I think we have another one. Okay, young woman now, history of recurrent sleepwalking, vague dream material prior to this video, and again, she's in N3 sleep. Still asleep here. Speaking French, I don't know what she's saying. And the lights go. Here, the lights go. Now she's awake. So again, I'm not sure I would know what to call that based on the history alone. I'm fairly certain, we'll watch just part of it. I'm fairly certain there's some auditory something in the lab that might have triggered an arousal. She makes
It's amazing she didn't fall out of bed.
Yeah. So again, vague dreamlike material, kind of unclear, semi-glitchy, but in this case, the sleep study really focused. Okay. Treatment of sleepwalking. It really is down to safety and prevention. So most sleepwalking does not need any kind of elaborate intervention or measures. If you're dealing with a child who sleepwalks and they happen to come into your bedroom, let's say, calm redirection, don't try to wake them up, just get them back into bed. That's the way to do it. But for somebody who has recurrent sleepwalking, or it's more complex, especially if they potentially get themselves into trouble, they're turning on the stove, they're trying to get out of the house, we do want to put some protective measures in place. So, high up locks on exterior doors or code locks or something that's a little harder to operate. Child gate on staircases, obviously. If you have guns and knives and things in the home, you make sure those are secured. I've had families need to like remove the knobs from a stove. More commonly, if they're just kind of shuffling around in the bedroom, if you've got sharp furniture, make sure the edges are padded. If they tend to go downstairs a lot, think about having the bedroom downstairs. So there can be some pretty, disruptive lifestyle interventions that need to take place here. And again, this is not common, but in somebody who has recurrent problematic sleepwalking like this, that should be your first intervention. Other things you can try, scheduled waking. So because sleepwalking, like other non-REM parasomnias, tends to happen early on in the night, if there's a reliable time period where it's happening, you wake them up 15 to 30 minutes before the average time. And for some reason, that seems to sort of short circuit the event. You can do the same thing for nocturnal enuresis. There's limited evidence for hypnosis and other forms of psychotherapy. Admittedly, not something I routinely prescribe, but you'll read about it in the.
You get a lot of that, but they don't want to do that.
Love that. Avoiding precipitants is the big thing, right? If there's an underlying sleep disorder, I'm trying to think, like most commonly, you're going to get adult or kid coming in, recurrent sleepwalking, and oh, by the way, they snore, gasp, and choke at night. Like, okay, and they're having repeated arousals from apnea. You treat those, the sleepwalking goes away. So again, even if you don't treat the parasomnia itself, you're looking for underlying causes. Benzodiazepines tend to be particularly effective for sleepwalking if you're at the point when you're going to use a medication. Limited evidence for these other medications here. But one important thing is that even though benzos can be used for treatment, the non-benzo benzodiazepine receptor agonists, like blue drugs, tend to precipitate parasomnias. So that's an important side effect to just counsel patients on anytime you're starting Ambien or Lunesta or Sonata or what have you, that you can get some sleepwalking. As far as I know, the full mechanism for why benzos work and Z drugs make things worse is not completely well understood. Clearly there's differential modulation of GABA receptors that's happening, but I'm not sure if we've worked out the full mechanism beyond that. Okay, just real quick. Sexsomnia is a specific type of somnambulism that involves sexual behavior. It's typically out of character to that patient's usual behavior, and it might be self-oriented, the bed partner, bystander, etc. So this can be pretty disturbing, especially if the patient is not aware of it and learning about it the next day. Can look all kinds of different ways, but most people have a personal family history of sleepwalking. Again, you do want to rule out contributing factors, and this in particular can have some legal ramifications. But again, you're optimizing sleep hygiene, you're minimizing anxiety, stress, like we talked about. You want to treat underlying sleep disorders, and again, there is reasonably robust evidence for clonazepam in this particular condition. I don't think this is something you're going to see all that often. One of my mentors in fellowship happened to be just sort of randomly one of the nation's experts on this. I don't think she wanted to be. It's just she kept getting patients that had this, so she developed an expertise. So I feel obligated to put it in here, but it's just something to do. Okay. I have seen one patient on my own after fellowship with sexsomnia. Married guy, young, healthy gentleman, but It was really upsetting to him and his wife, which is why he presented. He had very vague symptoms of sleep disordered breathing, but ended up actually having moderate apnea on a sleep study. And so after putting him on the CPAP, this totally vanished. So again, should prompt you to look for underlying causes.
Do you guys, so like I've seen cases like patients that complain, like I never meet the dad, but you know, like custody issues, and sometimes they try to get us involved. Like, do you guys, for patients that have this issue and are being treated, have you ever seen where you guys have to write letters on their behalf?
Yes, although you got to be careful.
Yeah.
So if they're looking for the type of letter that's like, I have a sexomnia and therefore carte blanche for anything that might happen,
Got
that's
it.
not something.
Yeah, right.
But most commonly, if you are asked to write a letter, it's a very cut and dry sort of thing that, you know, this patient has this specific diagnosis. There is an association between somnambulism and sexomnia, let's say, period.
That's
You know,
it.
the end.
Got it. Okay.
Yeah. And anything else might be more in the context of a legal proceeding, in this case, deposed and so on and so forth. And that's very much that's not like you're in trouble kind of thing. But like if you have a side gig as an expert witness, which some sleep doctors do.
In certain patients, if we have suspicion of some sleep disorder, then only you're gonna order this.
Yeah, I would have a very low threshold PSG and something, but even if they have very few, if any, symptoms. So, you know, a couple of days ago, we talked about in adults, it's ruling out ruling in sleep apnea in kids, it's ruling out. I would take the opposite approach with this. And if you're in the situation of a complicated parasomnia, especially a sexsomnia, even if there's no other symptoms, get a sleep study. See what else is going on. The hit rate's going to be pretty high. Okay. So moving down the list, we had confusional arousals where you're confused and in bed, somnambulism where you're confused and getting out of bed, and now we're on to sleep terrors or night terrors where you're confused and have limbic activation. So anybody who's seen these other video and your kids or relatives or whatever, they're terrifying. They're absolutely terrifying. So they're usually characterized by, you know, suddenly sitting bolt upright, eyes may be open or closed. There's a piercing scream. Sympathetic tone is elevated. You know, pupils usually dilated, hearts racing, diaphoresis. And people, mostly kids, can be particularly aggressive is maybe not the right word, but sort of resistant to attempts to calm them. And that's probably the most upsetting part to parents when they're trying to deal with this, is that their child really is not consolable because they're not awake. And oftentimes attempts to console the child, and certainly attempts to like snap them out of it, actually have the opposite effect, but they sort of prolong things. So not much to see here really, but this is a kid in M3 sleep, breathing normally, has a sudden arousal, then heart rate accelerates, respiratory rate accelerates, remains asleep, but is having a sleep terror at this point. Sleep terrors don't have any specific appearance on the PSG, except if you see that they are still asleep and there's some sign of sympathetic overdrive, tachycardia, tachypnea, etc. That can be a helpful differentiating factor. Reasonably common in kids, 1 to 6%. I mean, they're not nearly as common as sleepwalking or confusion arousals, but they happen. Rare in adults. Again, on PSG, you get an arousal from stable M3 with sympathetic hyperactivation. Treatment typically, again, is just environmental safety, work on sleep hygiene, minimize things that might be triggering it, provide reassurance, but mostly it's about education, right? You know, counseling, again, it's usually kids and families, counseling families, this is way worse for you than it is for the kid. They're not going to remember this. You know, don't beat yourself up about it. But that's a very important message to convey because often families are coming extremely distressed. And usually pediatricians are giving that message as well, but it's an important role for us to kind of reinforce. Again, as with other N3 parasomnias, scheduled awakenings may be helpful if it's happening at a reliable period. And very, very, very rarely a low dose benzo might be considered. And again, I would really reserve that for cases of like, you know, self-injury or something of that nature. Okay. You will probably see this chart published elsewhere, but nonetheless, I'll send the slides out to you. Just kind of a handy chart to differentiate sleep terrors from nightmares. Again, sleep terrors arising out of N3 sleep typically happen in the first third of the night, whereas nightmares happen in the last third. And you can kind of see the other comparisons here. But this ends up being helpful most of the time, I would say, if you're trying to do a differential diagnosis between non-REM and REM parasomnia, and you figure out which category they fall in based on these features, it's a pretty reliable way to do it. Okay, home stretch, and then we'll take a break. So other parasomnias, it's a big list, but we're going to go through this pretty quickly. So sleep-related eating disorder. So this is a type of sleepwalking that involves eating things. And because of that unique feature and because of how consistent it is, it's got its own little diagnosis. So very simply, this is making and consuming ostensibly edible things while asleep. I'll show you what I mean by that. There are a couple of things you want to have in your differential diagnosis. So SHRED or sleep-related eating disorder is a parasomnia. Evening hyperphagia and night eating syndrome are not parasomnias, but they can look kind of similar. So sleep-related eating disorder, that happens during sleep. Evening hyperphagia happens before you are falling asleep, before you've gone to bed, and that's conscious consumption of excess calories. It's typically more than half your daytime calories. Night eating syndrome similarly can be consuming a lot of nighttime calories in the late evening or during full awakenings from sleep. But again, this is a conscious sort of thing. So people will usually be very clear, I remember doing it, I'm fully awake, or I don't remember doing it, and I wake up in the kitchen and I'm like, why am I here? So differentiating the two is helpful because obviously for cognitive awake issues, you're going to offer one type of therapy and counseling. For eating that's happening when you're asleep, that's not going to be effective. You're going to want to pursue other therapies, and there are some. SHRED is not common in the general population, but in patients who have an eating disorder of one type or another, it's up to 15, 16%. So, you know, people who are in weight management clinic, we hear about this all the time. And obviously we're seeing anybody who's thinking about bariatric surgery, you know, for sleep apnea screening. So you will see this reasonably frequently in that population. Let's see, on the sleep study, there's this finding called rhythmic masticatory muscle activity. Here, let me move forward and just show you what that is. So that's going to be on the EEG, but it's coming from the masters, and it's repetitive chewing. So interestingly, we see that sometimes even in the absence of food. By which I mean, if you see somebody who's going to the kitchen and stuffing their face and chewing, kind of obvious what it is. But RMMA can happen even outside of eating anything. It's just sort of like a sort of automatic behavior.
And it looks different from like the bruxism.
Yes, yeah, exactly. Bruxism, so first of all, this is shorter and periodic.
Okay.
Bruxism tends to be longer and aperiodic. Okay. Treatment, similar to sleepwalking, you're just going to ensure like environmental safety, lock things up, etc. Again, look for and treat underlying sleep disorders. And then this one we actually see treated pharmacologically more commonly, less than 50% of the time, but more than 1%. And topiramate tends to be the most commonly used med in this case. The other thing that's interesting about shred is it's never like a salad that people are eating in the middle of the night. They tend to be high calorie foods. One of my patients always makes a sugar sandwich, just like gets a bag of sugar and sort of sprinkles it on bread and then eats it. And they can be non-edible or partially edible things too. So another patient of mine would routinely smear peanut butter on a carton of cigarettes. And she would wake up when she sort of took a bite of it, but that was her thing.
You see, sorry, go ahead.
Patients in Walmart with PSG.
That's right. Yeah. You'll be amazed by the things that people bring in and almost like smuggle in. Yeah, like pizzas and a bag of popcorn. Yeah. We don't typically provide food at sleep labs.
Sometimes they like bring like whole bags of stuff. Like when I was consenting at sleep lab, like they would bring like entire bags of stuff. I just,
Camping out.
you're not even staying for the MSLT. Like
It's an interesting foray into what happens at home, and often you'll find you ask like, what are you bringing all this from? Well, I always have to have something to eat at night. How do you sleep? And then the history reveals itself that they have a bedside bowl of grapes or whatever, or candies, and they're snacking. Not great for your dental health, but also as melatonin levels go up, insulin levels go down, right? So we are particularly ill adapted to dealing with calories, especially sugary calories in the night. So that is another behavior that you tend to see track with eating disorders.
do you see increased prevalence of this in people with like Prader-Willi?
Yes. I would say Prader-Willi is rare enough that a rare
It's hard to
condition and a
study.
rare thing. Yeah. Yeah. But the general answer is yes. Prader-Willi is tough because in addition to the developmental delay and stuff, they've got the disordered orexin axis, right? So they tend to have a lot more repetitive behavior, obesity, obviously,
They're
but
floppy all the time.
yeah, but you'll hear more about Prader-Willi later. But because of that disordered orexin, they're one of the few groups without narcolepsy that can have cataplexy. Yeah.
So these patients remember what they ate?
Oh, good question. If it's shred, no. Or at least I'll say this, they shouldn't be conscious when they're eating it. Now, if they wake up and they're halfway through a bowl of peanut butter, they're going to remember. But the other thing that you'll sometimes see is they've returned to the bed and they wake up in the morning with like candy wrappers strewn about that they don't remember bringing in, or they've got like chocolate cake on their face, or whatever it is. But they're not aware and awake when they're actually eating. Okay. Last couple of slides. We're in the other parasomnias group now. Exploding head syndrome. You will see this, and your patients will think you're a genius, as will your colleagues when you diagnose this, because it's more common than we think. So this involves a complaint of a sudden noise or a sense of explosion in the head. Tends to happen at sleep-wake transition. So either when you're falling asleep or sometimes during an arousal for another reason in the middle of the night. Typically you awake feeling very frightened or disturbed, but it's not associated with pain. That's important. It's reported to be rare. It's probably common, though. We really don't have a good sense of what the prevalence actually is. There's some thoughts that it might be a hypnic hallucination. People have looked at in a cerebral angiography and made sure it's not like a stroke or some weird inner ear phenomenon, et cetera, and reliably it's not that. But typically the treatment is reassurance. This is usually not a recurrent sort of thing, but as with a lot of these, the meds that you see here have been investigated as potential treatments. I have not prescribed any of those ever for exploding head syndrome, because again, usually once you tell people what it is, that degree of reassurance is enough to have them be satisfied. All right, sleep enuresis, and again, other parasomnia. We're talking about kids older than 5 years because under 5 years of age, mature bladder control hasn't developed yet. And so it's not abnormal if a young child wets the bed. But we're talking about recurrent involuntary voiding during sleep at least twice a week. That's the criterion. It's present for at least 3 months. And then we differentiate between primary and secondary enuresis. Primary, which is the more common type, means the patient's never been consistently dry at night. And secondary means they were dry for at least 6 months at night and then started. If you've got secondary enuresis, that's usually going to point to some triggering factor. You see that one, etc. So that again should evaluation for some kind of triggering factors. So most sleep enuresis is primary. This is kind of like a general pediatrics diagnosis, but you will see it reasonably frequently in the ped sleep clinic. Hopefully nobody's referring to you specifically for that, but sometimes they will. So fluid restriction a couple hours before bedtime. Bedwetting alarms can be really helpful. There's like a sensor that goes in the underpants and then that connects to like a buzzer or noisemaker or something that clips onto the clothes. And as soon as it gets damp, it wakes the kid up and they don't empty the whole bladder. And eventually what that does is it strengthens the, whatever neuropathway it is, linking the sense of a full bladder to waking up. You can use DDAVP, desmopressin, not a great long-term therapy, but if the kiddo is like going to camp or having a sleepover or something, that could be a good short-term therapy. And again, hopefully they've already had like a UA and a glucose and so on and so forth.
Checking their constipation.
Yeah, exactly. So again, if that hasn't been done and the kid has ended up in your office, shame on somebody, you should do that. But most commonly, the primary doc has done all of that and they're actually referring to you to rule out another sleep disorder. And most commonly that's sleep apnea. Okay, all right, last few slides, quiz time. So you're seeing the family of a 5-year-old boy. They describe episodes of inconsolable crying and screaming once or twice per week, usually within 2 hours of falling asleep. He typically returns to sleep in a few minutes. When you ask him in the morning, he doesn't remember the events. Which of the following is likely true? A, they're arising out of REM sleep. B, they may be treated with scheduled awakenings. C, they must be evaluated by polysomnography. And D, they may be an early marker of narcolepsy.
Sleep trigger could be
Sorry, say again?
sleep trigger, right?
Yeah, I think so, yes, yeah.
B.
Yeah, they may be treated with scheduled awakenings. Yeah, that's right. So it's not likely REM, well, because we know what it is, but also because it's occurring in the first third of the
You
night.
didn't remember.
Exactly. They do not need to be evaluated by polysomnography. Again, there's only one parasomnia that needs a PSG. And there's no association between night terrors and narcolepsy. There are some other parasomnias that may be associated with narcolepsy, not this. Okay, yeah. All right, you're seeing a 19-year-old woman who is here because her roommate said that she routinely consumes cat food in the middle of the night and also eats large quantities of peanut butter. The patient has no recollection of doing so. However, she's noted a 20-pound weight gain in recent months, despite attempts to diet during the day. What is the most likely explanation? A, Klein-Levin syndrome. You guys have heard about that, right?
Yeah.
Okay, good. Super rare, super interesting. B, confusional arousal. C, sleep-related eating disorder. D, night eating syndrome.
See,
C, yeah. So the first two we can pretty much rule out, right? Why is it not night eating syndrome?
she had
no
no
eating
recall.
Yeah, bingo. Okay. 52-year-old man is seeing you with bothersome nocturnal spells in the beginning of the night associated with fear. On the PSG, the spells occur during transition to N1 sleep, at which point he wakes up, holds his head, and yells that his head is snapping. Which of the following is the most likely diagnosis? Migraine, hypnic headache, cluster headache, or exploding head syndrome?
D.
D, yeah. So again, A and C you can cross right out, but the key factor here, hypnic headache is a headache, whereas exploding head syndrome is not associated with pain. Okay. Last one. 42-year-old woman is seeing you after an episode during which she awoke to find herself standing on her front lawn with the sprinklers on. She reports sleepwalking as a child. She wonders if a new medication that she started could be responsible. Which is the most likely offending agent? A, Benadryl, B, Ambien, C, hydralazine, or D, Klonopin?
B.
The end.